Hello, everyone, and welcome. Today, we're going to be talking about anxiety, obsessive compulsive, and related disorders. When we think about anxiety, one of the main components that's interrelated with anxiety or any type of anxiety disorder is fear. Fear is the central nervous system's physiological and emotional response to a serious threat to one's well being. Although the focus of the response can be different, for example, real fear versus imagined danger, fear and anxiety are interrelated. When we're faced with fear, most people will experience the physical reactions that are described under anxiety. Fear can cause anxiety, and anxiety can cause fear. When we think about this too, remember that anxiety is more visceral than worry. Worry tends to be more focused on thoughts in our heads, while anxiety is, again, that visceral feeling throughout our body. So, anxiety is the central nervous system's physiological and emotional response to a vague sense of threat or danger. So, in fear, it's typically going to be associated with a specific aspect of something or something that is very specified. Whereas with anxiety, it's more generalized. We sometimes have a hard time even understanding or coming to terms with what might be causing it. It might not be identifiable. When we think about generalized anxiety disorder, this is a disorder that's marked by these persistent and excessive feelings of anxiety and even worry about different events and activities. When we think about anxiety disorder, this is the most common mental disorder that we have in the United States. In any given year, about 18% of the US adult population experience one of the six DSM-5 anxiety disorders. About 29% develop one of the disorders at some point in their lives. Most individuals with one anxiety disorder also suffer from a second disorder. Most common is depression. In addition, many individuals with anxiety will not only experience depressive symptoms or depressive episodes or even depression, but these things can typically be more on the chronic end, meaning that they're longer lasting. About one third of these individuals will seek treatment. So let's look at some of the disorders that fall under anxiety. The first is generalized anxiety disorder. Generalized anxiety disorder typically has to occur for 6 months or more. The person experiences disproportionate, uncontrollable, and ongoing anxiety and worry about multiple matters. And again, they might not be able to specify anything specific, but just it's more generalized or it impacts multiple areas of their life. The symptoms will include at least three of the following: edginess, fatigue, poor concentration, irritability, muscle tension, sleep problems. And when we talk about sleep problems, it could be problems falling asleep and or staying asleep. And these things must cause significant distress or impairment. And this is information from the DSM-5. When we think about GAD or generalized anxiety disorder, it's most likely to develop in people that are faced with dangerous, ongoing social conditions. And this is supported by research. Some forms of societal stress can include things like poverty or race and ethnicity. Since race is closely tied to stress in the United States, it's not surprising that it's also tied to the prevalence of generalized anxiety disorder. In any given year, African Americans or Black individuals are 30% more likely than white Americans to suffer from generalized anxiety disorder. Multicultural researchers haven't consistently found a heightened rate of generalized anxiety disorder among Hispanics in the United States, although they do note that the prevalence of nervousness or nervios is occurring in this population. And when we think of poverty, when we look at poverty and other social pressures, they can create a climate for generalized anxiety disorder. But there's other factors that are also at work. So when we think of this, for example, people who live in impoverished situations, they often live in what we can consider a dangerous environment. And there are other models that attempt to explain why some people develop the disorder and others don't. So what we see here is information from the DSM-5 on what generalized anxiety disorder would look like for a diagnosis. Now we look at separation anxiety. When we think about separation anxiety, this is the most common disorder among young children. The DSM-5 has determined that separation anxiety can also develop in adults. And there's new categorization as anxiety disorder, which can also, be problematic or controversial, because when we think about separation anxiety, we are thinking about how it can be something that is more generalized, or it can be something that is more specific. It can be something that is acute or chronic. So is this really something that we should have as a diagnosis? Is it something that should only be for children, or should it also lead into adulthood? When we think about generalized anxiety disorder and we look at it from a psychodynamic perspective, Freud, who did most of his research on his own children, found that all children experience anxiety at some point in their life. It can be realistic when they're faced with an actual danger. It can be neurotic when they're prevented from expressing their id impulses. And it can be moral when they're punished for expressing their id impulses. Some children will experience particularly high levels of anxiety, or their defense mechanisms might be inadequate because they haven't been fully developed. Today's psychodynamic theorists often disagree with specific aspects of Freud's explanation, because research has found that when we look at this from a psychodynamic perspective, that people with generalized anxiety disorder are particularly likely to use defense mechanisms, especially repression. And adults who, as children, suffered from extreme punishment for expressing their id impulses have higher levels of anxiety later in life. Some scientists question whether these studies show what they actually claim to show. When we look at psychodynamic therapies, you typically are going to find that most of the time that therapists are interpreting what the client is saying in order to diagnose them with generalized anxiety, that one of the things that they're going to be focusing on is what's called free association. And free association is essentially the expression of the content of the consciousness without censorship. And it helps to gain access to unconscious processes. So when we are thinking of this, you may find that this expression of the consciousness without censorship can be useful for the therapist to get to these unconscious, memories or thoughts that the client might be having. And the therapist will interpret things like transference, resistance, and dreams in order to access these unconscious situations and thoughts and processes. But sometimes it can be helpful and sometimes it's not. When we think about the treatments for generalized anxiety disorder, true Freudians focus less on fear and more on controlling the id. Object relations therapists attempt to help patients identify and settle early relationship problems. When we look at controlled studies, they've found that psychodynamic treatments can only typically be modest in their help to persons with generalized anxiety disorder. And if they are going to use a psychodynamic perspective, it is recommended that short-term psychodynamic therapy can be more effective and is the exception to treatment. When we look at the humanistic perspective, generalized anxiety disorder arises when people stop looking at themselves honestly and acceptingly. And Carl Rogers actually found that when people develop generalized anxiety disorder, it's because they lack unconditional positive regard, which stemmed in childhood, and it leads them in this lack of unconditional positive regard leads into adulthood. And they can find that as later adolescents or even adults, that these individuals typically have very much conditions placed around their value and worth in society. They have harsh self-standard, they have poor body image and low self-esteem, poor self-concept, and they lack self-efficacy. Carl Rogers also found that threatening self-judgments break through and cause anxiety, which sets the stage for generalized anxiety disorder to develop. So, client-centered approaches can be helpful to show unconditional positive regard to the client and to empathize with them, because we're showing them that we hear them, we're validating them, we are showing that they are valued and worthy. Despite some optimistic case reports, there are a number of controlled studies that have failed to offer strong support for the humanistic perspective. And there's only a limited amount of support for Rogers' explanation of generalized anxiety disorder and other forms of abnormal behavior. When we look at the cognitive behavioral approach, cognitive behavioral theorists and clinicians believe that problematic behaviors and dysfunctional thinking patterns often cause psychological disorders, and that treatment is going to involve nature of behavior and thoughts. So, when we look at some of the early approaches, Albert Ellis looked at maladaptive or basic irrational assumptions. So, these theorists suggested that generalized anxiety disorder is definitely going to be based on these maladaptive assumptions. And Ellis identified some basic irrational assumptions that people with generalized anxiety disorder develop. First, that it's a dire necessity for an adult human being to be loved or approved of by virtually every significant person in their community. It's also awful and catastrophic when things are not the way that one would very much like them to be. And when these assumptions are applied to everyday life and to more events, generalized anxiety disorder may develop. Aaron Beck looked at silent assumptions. So, Beck, as another cognitive theorist, argued that persons with generalized anxiety disorder will constantly hold their assumptions that imply imminent danger, that a person or a situation is unsafe until provided and proved to be safe. And it's always best to assume the worst. Researchers have repeatedly found that people with generalized anxiety disorder don't hold maladaptive assumptions, particularly around dangerousness. So, what we see here is about the cognitive behavioral approach. So, in one survey, 62% of college students said they spend less than 10 minutes at a time worrying about something. In contrast, 20% worry for more than an hour. That has led us to look at a couple of different things. So, in recent years, there have been new explanations that have emerged. So, when we look at metacognitive theory, which was developed by Wells, it suggests that the most problematic assumptions in generalized anxiety disorder are the individual's worry about worrying. That's called a meta worry. When we look at Corner and colleagues, they looked at this intolerance of uncertainty theory, and that under uncertainty theory, certain individuals consider it unacceptable that negative events may actually occur. And if the possibility is very small, they'll worry in an effort to find a correct or better solution. When we look at avoidance theory, which was developed by Borkovac, it holds that worrying serves as a positive function for those with generalized anxiety disorder by reducing unusually high levels of bodily arousal. When we are further examining cognitive behavioral therapies, one of the things that we want to do is we want to break down worrying, and we also want to change maladaptive assumptions. So when we are looking at Ellis's rational emotive therapy, one of the things we look at when we are looking at rational emotive therapy, which is now called rational emotive behavioral therapy, but it used to be called RET. Now it's REBT. But it positions that people have erroneous beliefs about situations they're involved in, and that these beliefs cause disturbances, but it can be disputed and changed. And how it is disputed and changed is through being able to identify these irrational beliefs and negative thought patterns that lead to emotional and behavioral issues. When we look down how we break down the worry, we can use things like mindfulness-based cognitive behavioral therapy and acceptance and commitment therapy. So when we look at mindfulness-based cognitive behavioral therapy, we are essentially looking at how we can shift our thoughts, our feelings, and our behaviors based on using tools from a non-Western or an Eastern perspective that can help us to get into the present moment and to be fully present with ourselves. And with being present with ourselves, the focus is primarily on breathing and also being attuned to our body and any bodily reactions that happen. So we become the experts of the physiological aspects of our bodies. And as we attune to our bodies, we start noticing that there are certain physiological changes, and that those physiological changes will then allow us to check in with our thoughts, check in with the emotions that we're having, and to look at any behaviors or observe what are we might or might not be doing, and then make changes as a result that are healthier for ourselves and reduce any negative or unhealthy physiological reactions. When we look at acceptance and commitment therapy, we are looking at how we are going to be changing how we are looking at difficult feelings. So we're not going to eliminate these difficult feelings, but we're going to be present with what life brings us, because the whole goal of acceptance and commitment therapy is to move towards valued behavior. So ACT or ACT or acceptance and commitment therapy invites people to open up to these unpleasant feelings and not to overreact to them, and not to avoid them, but to lean into them and to learn ways to not overreact and to stop avoiding or repressing. So they learn certain tools and skills and techniques to help them to work towards steps that help them to find value and meaning in the world while not avoiding or repressing these things related to anxiety, for example, worry. From a biological perspective, generalized anxiety disorder can be caused by chiefly biological factors. And this is supported by looking at family genealogy and brain research. And it's challenged by competing explanations of the shared environment. Because when we look at biology and we look at genetics and genealogy, biological relatives are more likely to have generalized anxiety disorder by more than 15% when they are closer to the relative, because the closer to the relative that might have a mental health issue or generalized anxiety disorder or another anxiety disorder, the greater the likelihood that you or an individual will also develop generalized anxiety disorder. There's also fear that can be tied to different brain circuits. So when we're looking at generalized anxiety disorder, this is a result from the hyperactive fear circuit. So, the circuit in the brain that helps to produce anxiety reactions includes structures like the amygdala, the prefrontal cortex, the anterior cingulate cortex, and the insula, which is not visible from this part of the brain. In normal fear reactions, there are key neurons that fire rapidly, and they create a general state of excitability experienced as fear or anxiety. Then a feedback system is triggered so that the brain and body activities work to reduce excitability. There are some neurons that release GABA to inhibit neuron firing, thereby reducing experiences of fear or anxiety. But there can be malfunctions in the feedback system that are believed to cause generalized anxiety disorder. And two possible reasons are that there are too few receptors or there are ineffective receptors. Recent research has complicated this picture to show that other neurotransmitters can also bind to GABA receptors. So we find that there are some issues of causal relationships. Do physiological events cause anxiety? How can we know? And what are some alternative explanations? When we look at the biological perspective, one of the ways to treat generalized anxiety disorder is through drugs therapy. So in the early 1950s, there were a number of barbiturates that were used, and barbiturates are sedative hypnotics. In the late 1950s, they introduced benzodiazepines. Benzodiazepines provide temporary, modest relief. It helps to rebound anxiety with withdrawal rather, and cessation of use. There's a higher likelihood of physical dependence, some possible undesired effects, for example, lethargy and drowsiness, and it can mix badly with certain other drugs, especially with alcohol. So, more recently, there were classifications of drugs that were developed that are called antidepressants and antipsychotic medications. Now, let's switch from generalized anxiety disorder to phobias. And when we think about fear, again, this is a normal and common experience. So, how do phobias differ from fear? Well, phobias are more intense and include more persistent fear. There's also greater desire to avoid the feared object or situation. And phobias create distress that interferes with functioning. So, some of the biggest existential fears are listed here. I encourage you to pause this video to look at these fears and continue on when you're ready. When we think about phobias, there are two categories. There are specific phobias and agoraphobia. So, when we think about a specific phobia, this is something that is persistent and unreasonable fear of particular objects, activities, or situations. And there's typically avoidance of the object or the thoughts about it. And when we think about agoraphobia, agoraphobia is essentially the fear of these places um, that can cause well, fear of public places, I should say, and public situations that might cause panic, helplessness, and embarrassment. And agoraphobia is often a specific phobia that can develop after one or more panic attacks. And if you have never had a panic attack is where there's a lot of fear that is associated, and some of the physiological reactions are quite intense. It can include an increase in heart rate that can make the person who's having the panic attack feel like they are having a heart attack, an increase in body temperature that they become very hot and sweaty. They may even feel like they're burning up and remove their clothing. Their heart rate goes up to a dangerously high level. And with their heart rate going up, their blood pressure also goes up as well. Many also report that they have issues with stomach concerns that can tie along with it, where they have these waves of extreme nausea. And once the panic attack subsides, they have bouts of diarrhea. When we look at specific phobias, we are looking at how these symptoms will occur. Um, the symptoms typically exist in about 10% of all US people, and the most common phobias are specific animals, insects, heights, enclosed spaces, thunderstorms, and blood. About 14% of people experience symptoms of a specific phobia at some point in their lifetime. More women than men will report specific phobias at a 2-to-1 ratio, and only 32% actually seek treatment. So, how does a specific phobia get classified under the DSM 5? It has to have marked, persistent, and disproportionate fear of this particular object or situation, usually lasting at least 6 months. Being exposed to the object or situation produces immediate fear. And typically, the person wants to avoid the feared situation or person or um, object as much as possible. And when they are thinking about being exposed to that object, or they are being exposed, that it can cause significant distress or impairment. When we think about agoraphobia, we find that symptoms exist in about 1.7% of the US population in a given year. And about 2.6% of people will experience symptoms during their lifetime. And there are some gender differences very similar to what we had seen in specific phobias. About 46% of people who have agoraphobia seek treatment. When we are thinking about what the DSM 5 would use for classification, it's again this pronounced, disproportionate, repeated fear about being in at least two of the following situations: public transportation, which can include things like traveling in a car or in a taxi or plane, parking lots, bridges, or other open spaces, shops, theaters, or other confined places, lines or crowds, or away from home unaccompanied. Fear of such agoraphic situations typically derives from a concern that it would be hard to escape or to get help if panic, embarrassment, or disabling symptoms were to occur. So, what happens is that people will avoid going to public places or public situations, and these symptoms have to last for at least 6 months or more. And, like with specific phobias, the impairment must cause distress or um, debilitation, and that the phobia, when it comes to the public places, it might often fluctuate. So someone might be okay, but then as they are getting ready to engage into this public space, that then this intense fear will come up and they want to avoid the situation. So, what causes specific phobias? Well, there's evidence that supports that there's a behavioral explanation behind it. So, once the fears are acquired, the individuals avoid the dreaded objects or situation, permitting the fear to become even more entrenched. And when they try to work through it and it's unsuccessful, then there's layers of shame or guilt or doubt or fleeting thoughts of failure that are then compounded on top of it. That is more of a cognitive behavioral theory behind it. When we look at a behavioral evolutionary explanation, it pretty much says that the behaviors are internally a part of ourselves from a biological standpoint, that we seek to, feed our needs, whether, our basic needs like food and hunger. But if we are approached by something like a bear, then we know that we need to escape that bear because our lives are now on the line. That's part of fight or flight. From this perspective, though, when those basic biological drives are now replicated or are transferred to other situations, they can cause us to have very similar reactions, and those similar reactions now cause us to want to fight or flee the very situation that is biologically entrenched in us. So, how do we learn fears, right? So, we just talked about this, that the phobias are developed through modeling. So, we observe and we imitate what we see, and they are maintained through avoidance. And they may develop into generalized anxiety disorder when a person acquires a large number of them. And this is what's called the process of stimulus generalization, that responses to one stimulus are also elicited by a similar stimuli. So what can we do about it? So what does the research indicate? Well, there's early laboratory studies of classical conditioning fear, and this was something that we had seen with Watson and Rayner with little Albert. So little Albert in the study from Watson and Rayner responded to the noise by crying and showing fear. The rat was originally a neutral stimulus and had become a conditioned stimulus um, when there was a loud noise that was elicited. And it was eliciting this emotional response, which is an unconditioned response that was similar to the distress or an unconditioned response originally given to the noise, which is an unconditioned stimulus. We also see when we look at modeling, which modeling was from Bandura and Rosenthal. And under modeling, that Albert Bandura essentially said that learning is a complex process and it can be influenced by a wide variety of factors. So Bandura's theory says that social learning or social learning theory says that observation and modeling may play a primary role in how we respond to what we learn and how we can look at how people learn. When we look at fear reactions, it may not always be conditioned. So, one of the things that our book talks about is McCabe and Gamble. McCabe and Gamble and colleagues found that when we look at phobias, that phobic disorders are not ordinarily acquired through classical conditioning or modeling, and that there may be more of a biological aspect or a genealogical aspect that relates to it. When we look at a behavioral or evolutionary perspective, that some people or some specific phobias are much more common than others, and that species specific biological predisposition can develop with certain fears when it comes especially to preparedness. So, for example, in the photo, is a mouse's fear of cats conditioned reaction or genetically hardwired? So there were scientists at Tokyo University who used genetic engineering to switch off this rodent's instinct to cower at the smell or presence of a cat. But the mouse should beware because the cat has not been genetically engineered to act in a corresponding manner, which is where preparedness can come in. Researchers don't know if these predispositions are due to evolutionary or environmental factors, but it helps to explain why some phobias are more common than others. How do you treat specific phobias? Well, when we look at it from a behavioral evolutionary perspective, one of the things that can be really helpful is to actually have contact with the feared object or situation. This can be key to greater success in all forms of exposure treatment. One of the things that Wolpe had come up to terms or had generated a term around was called systematic desensitization. With systematic desensitization, you are slowly introduced to whatever the phobia is, and that you are then taught to relax. Relaxation is incompatible with fear. So when you are taught the relaxation response, it's thought to substitute the fear response. So you teach relaxation skills, you create a fear hierarchy, you pair relaxation with the feared object or situation. And as you continuously do this, that you can actually help to desensitize a person to the phobic thing or object or situation that is causing them distress. When we think about this, there are two types of systematic desensitization. There's in vivo desensitization, which is live, and covert desensitization, which is where it is imaginary. You think of it in your head. There's also flooding, which is where you constantly inundate someone with the phobic or the um, the distressing object or situation, and you have them consistently experience this fear, and over time their response to the fear will diminish. And then you have modeling, which is where you show someone that you can be near that object and that you don't have to experience the fear, and by consistently modeling this, that the fear will then be diminished. When we look at treatments for agoraphobia, they find that there are older approaches that have been less successful, but newer treatments have been much more successful. And there's a variety of exposure therapy approaches that are often used. They can also be supplemented with support groups and home based self help programs. When you look at these more successful treatments, that they are more successful for about 70% of agoraphobic clients. But understand that relapses may actually occur, especially when panic disorder also exists. So when we think about panic attacks, many people with agoraphobia will experience these extreme and sudden explosions of fear. Those are panic attacks that we talked about earlier with some of those physiological reactions. So some individuals may actually receive comorbid or two diagnoses, agoraphobia and panic disorder. Now let's look at social anxiety. Social anxiety disorder is something that occurs in about 8% of the US population annually. 13% of people experience symptoms throughout their lifetime, or at some point in their lifetime, I should say. Non Hispanic white Americans are more likely to experience this than Black or African, Hispanic, or Asian Americans. You typically find that this begins in late childhood or adolescence and goes into adulthood. Only about 40% actually seek treatment. So, what does the DSM 5 say about social anxiety disorder? Well, there needs to be marketed, disproportionate, and persistent fear about one or more social situations. So, these social situations may be narrow, such as talking, performing, eating, or writing in public, or can be broad. There's a general fear of functioning poorly in front of others. In both forms, people do rate themselves as performing less competently than they actually do. This has to last for 6 months or more. There also needs to be a strong fear of being negatively evaluated or offensive to others. The exposure to the social situation almost always produces anxiety, and therefore, the client will avoid feared situations. These things also must cause significant distress or impairment. So, what do cognitive behavioral perspectives and theorists believe about social anxiety disorder? Well, it's important to remember that cognitive theorists hold that because of negative beliefs or beliefs about poor performance, people with social anxiety disorder will keep anticipating that social disasters will occur, and they repeatedly perform avoidance or safety behaviors to help prevent or reduce these disasters from even happening. How do they treat it? Well, unlike specific phobias, social anxiety disorders are often reduced through medication, particularly around antidepressants. And there are several types of psychotherapy that have proved at least as effective as medication. So, people who are treated with psychotherapy are less likely to relapse than people treated with drugs alone. One physiological approach is exposure therapy, either in an individual or group setting, where they are consistently exposed to whatever the social anxiety distressor is. Cognitive therapies have also been widely used. Another treatment option is social skills training, which is a combination of several behavioral techniques to help people improve their social functioning. Therapists typically will provide feedback and reinforcement. Social skill training groups and assertiveness training groups allow clients to practice their skills with other group members. There's also this thing with social media jitters that a lot of people are experiencing higher rates of social anxiety disorder because of technology. So, from having to be on their computer so much, especially as at the time of this video in 2021, that so many people are taking this class remotely, but they're becoming fatigued from having to be online on Zoom, for example, so much, or having access to their phones and FaceTiming and having all of these constant needs for people to communicate with them. And by having this, it can produce more common forms of social anxiety and anxiety in general. So think of social media and the platforms that we're using just to communicate. It can cause about people feeling overwhelmed and developing either generalized anxiety disorder and more specifically social anxiety disorder. Now let's look at panic disorder. Panic disorder are periodic, short bouts of panic that occur suddenly and reach a peak within minutes, and they gradually pass. So, in order for it to be a panic attack, there has to be four of the following symptoms, many of which I talked about earlier, and you can read this. Women are twice as likely as men to be affected. People who are poor or come from a lower socioeconomic status are 50% more likely than wealthier people to experience these disorders. The prevalence is the same across cultural and racial groups in the United States and seem to occur in cultures across the world. Approximately 35% of persons with panic disorder are in treatment. When we think about panic disorder, about 3.1% of the US population are diagnosed with this annually. More than 5% of people experience symptoms of panic disorder in their lifetime, and it often begins in late adolescence or early emerging adulthood. So we're looking at 14 to 25 years of age. Non Hispanic white Americans are more likely to experience panic disorder than US racial ethnic minority groups. 59% seek treatment for panic disorder, and it may be accompanied by agoraphobia. So the DSM 5 says there needs to be unforeseen panic attacks that occur repeatedly. And one or more of the attacks proceed with one of these symptoms, at least a month of continual concerns about having additional attacks, or at least a month of dysfunctional behavior that is associated with these attacks. So they now are having additional situations or experiences with avoiding. So, biological perspective says that the panic attack under initial theory is caused by abnormal norepinephrine activity in the locus coeruleus. But more recently, they find that there are brain circuits and the amygdala that are more complex to the root of this problem, and it may actually be inherited by um, your genetics. So, someone who is closely related to you, parent, grandparent, child, may have these abnormalities. We also see here that it can be caused by a hyperactive panic circuit that occurs within the amygdala, the hippocampus, the ventromedial nucleus of the hypothalamus, the central gray matter, and the locus coeruleus. Drug therapies have been helpful, especially with different antidepressants. They can bring some improvement to about two-thirds of individuals. But the function in norepinephrine receptors in the panic brain circuit needs to be addressed if they're going to use medications. Improvements require maintenance of using that drug therapy, especially if it's chronic. And there are some benzodiazepines, specifically Xanax or alazapram, that have provided to be really helpful for those where panic disorder is more acute or panic attacks are acute, or with panic disorder. that they have these continued symptoms of panic attacks. From a cognitive behavioral perspective, they look at biological factors and they believe that's only part of the cause of panic attacks, and that bodily sensations are misinterpreted as signs of medical catastrophes and controlled by avoidance and safety behaviors. So, when we look at misinterpreting body sensations, what happens is that a panic prone person may be very sensitive to certain bodily sensations and they might misinterpret them as these signs of medical catastrophes, which then leads to panic. So, why might some people be prone to these misinterpretations? Well, they experience more frequent or intense bodily sensations than others, and they have experienced more trauma than others. So, whatever is the precise cause, panic prone people generally have a higher degree of what's called anxiety sensitivity because they tend to focus on bodily sensations much of the time and are unable to assess sensations logically. Therefore, they interpret them as potentially harmful. And when we look at the biological challenge test, this is a procedure that could be used to produce panic and then assess panic in real time. When we look to seek therapy for panic disorder, they typically, under cognitive therapy, they want to help people with panic disorder, right? So, approximately 80% of treated patients are panic free for 2 years as compared to 13% of control subjects. So, these treatments can be helpful for treating panic with agoraphobia. And in those cases, therapists often will add this exposure technique to the cognitive aspects of treatment. And that treating cognitively can be at least helpful as antidepressants. So, they will educate about the nature of panic attacks. They will teach applications for more accurate interpretations of one's body. And they also teach skills for coping with anxiety, including administering the biological challenge procedure, not only in office, but also at home. And then we have obsessive compulsive disorder. So let's talk now about the differences between obsessions and compulsions. So, obsessions are persistent thoughts, ideas, or impulses, or even images that seem to invade a person's mind. Compulsions are repetitive and rigid behaviors or mental acts that people feel they must perform to prevent or reduce anxiety. So, obsessions are the thoughts, and compulsions are the actions or behaviors. What you see in figure 5.4 are the obsessions and compulsions that may be familiar to many people. I encourage you to pause this video to look at them and then continue on. So, obsessive compulsive disorder, also known as OCD, is classified as an anxiety disorder because obsessions cause anxiety, while compulsions are aimed at preventing or reducing anxiety. And anxiety will rise if the obsessions or compulsions are resisted. Between 1 to 2% of the US population suffer from obsessive compulsive disorder in any given year, and as many as 3% in their lifetime. It is equally common in men and women and among different racial and ethnic groups, and only about 40% actually seek treatment. So, the DSM-5 says that in order to be diagnosed with obsessive compulsive disorder, that the occurrence of repeated obsessions or compulsions or both must occur, and that the obsessions or compulsions must take up a significant amount of time and it must cause significant distress or impairment. So, when we look at the obsessions, there are features and basic themes. So, the features are the thoughts that feel both intrusive and foreign. And when you attempt to avoid them or ignore them, they can trigger anxiety. And some basic themes are that you're dirty or that there's contamination or violence and aggression, that there needs to be orderliness, that you are consumed with religious or spiritual thoughts, and about sexuality. Some of the compulsions, again, when we are thinking about the behaviors, that these the features are that they have to have these voluntary behaviors or mental acts that consistently happen, and they're typically patternized, and they feel almost mandatory or that they can't be stopped. Most people recognize that their behaviors are unreasonable, but if they try to stop, it can help to reduce anxiety. Excuse me, it'll help to increase anxiety, and that by performing the behaviors, it actually reduces anxiety even for a short period of time. These behaviors then turn into patterns, and those patterns turn into rituals. So some of the themes can be cleaning, checking something, ordering something, or balancing something, touching, verbalizing, and or counting something. Most people with OCD experience both obsessions and compulsions. The compulsive acts often occur in response to the obsessive thoughts. And the compulsions they represent yielding to obsessions, and they sometimes help to control the obsessive thoughts that they may have. From a psychodynamic perspective, the theory is that there's a battle from Freud between the id and the ego defense mechanisms, and that this battle lessens anxiety in overt thoughts and actions. Freud also said that OCD is related to the anal stage of development, meaning that the anal stage is where you receive pleasure from excreting feces, and that you should be able to control it or maintain it. People with obsessive compulsive disorder may have had trouble releasing their feces, or were found such comfort in doing that because the oral stage hadn't been satisfied appropriately for them, that it then becomes this drive as they turn adults to derive pleasure whenever something unpleasant happens. But not all psychodynamic theorists agree. But there are three ego defense mechanisms that are common from the psychodynamic perspective. That's isolation, where you try to disown these disturbing thoughts, the undoing, or performing acts to cancel out these intrusive thoughts, and reaction formation, where you take on lifestyle in contrast to unacceptable impulses. Under psychodynamic therapies, the goals are to uncover and overcome these underlying conflicts and defenses. And the main techniques are free association and interpretation. Research has offered very little evidence to support these therapies, but some therapists now prefer to treat these patients with more short term psychodynamic therapies. From a cognitive behavioral perspective, the disorder grows for human tendencies to have unwanted and unpleasant thoughts. And that under the cognitive behavioral perspective, that everyone has these repetitive, unwanted, and intrusive thoughts. But people with OCD blame themselves for normal, although repetitive and intrusive thoughts, and expect that terrible things will happen as a result. So, to avoid these negative outcomes, these individuals will attempt to neutralize their own thoughts with actions or other thoughts. They seek reassurance. They're thinking positive or good thoughts. They're washing their hands, for example, or they're checking things twice just to be sure. Behavior therapy focuses on the cognitive process that helps to produce and maintain these obsessive thoughts and impulses, because people with OCD tend to be more depressed than others, have exceptionally high standards of conduct and morality, believe thoughts are equal to actions and are capable of bringing harm. And these individuals believe that they can and should have perfect control over their thoughts and behaviors. So, a number of people will use exposure and response prevention exercises. So, what happens with these response prevention exercises is that you will elicit a response, and then you will look at ways that you can prevent the response from actually occurring. It's very similar to exposure therapy, only it's done typically within the office. And you typically will then set an example of what can trigger a response, and then what preventative method rather you can use to work through that response. A number of people will then tape those things and then have it played out, and give a copy to the client for them to play out repeatedly, so that they are not only continuously exposed to this new prevention method, um, but they also understand when the response can be elicited. And that by continuously watching it, they desensitize themselves and they work in with this new prevention method versus the old prevention method. And about 50 to 70% of people said they improved with therapy. From a biological perspective, the early research believed that it was definitely based on your family genetics, and they had based that off of twin studies. But the more recent research says that the brain circuit is linked to obsessive compulsive disorder, which includes structures like the orbital frontal cortex, the cingulate cortex, the strainium, the thalamus, and the amygdala. And what happens is that there's abnormal serotonin activity. They believe that researchers believe, with evidence, that serotonin based antidepressants can help to reduce OCD symptoms. And these recent studies have suggested that other neurotransmitters may also play important roles, meaning that they are too high or too low, which can lead to obsessive compulsive disorder. Abnormal brain structure and functioning finds that OCD is linked to the orbital frontal cortex and the caudate nuclei. The frontal cortex and caudate nuclei make up the brain circuit that converts sensory information into thoughts and actions. And either the frontal cortex and the caudate nuclei, these areas may be too active and they let through troublesome thoughts and actions. There's also some research that provides evidence that these two lines may be connected. So, serotonin with other neurotransmitters play a key role in the operation of the orbital frontal cortex and the caudate nuclei. The abnormal neurotransmitter activity could actually contribute to the improper functioning of the frontal cortex and caudate nuclei circuit. So, how do we work through this? Well, for starters, from a biological perspective, you would provide a serotonin based antidepressant. So, clomifene, which is anafril, and other similar drugs can certainly help. And those with OCD find that taking clomifene or anafril can see improvement in about 50 to 80% of those with OCD. But relapse can occur as soon as the medication is stopped. So, this is going to be a more longer term used antidepressant. Research also suggests that combination therapy, so medication and CBT approaches, may also be effective. When we think about obsessive compulsive related disorders, that there are other disorders that have been a part of OCD, and the DSM-5 actually created obsessive compulsive related disorders. So hoarding disorder um, was actually listed as part of OCD and obsessive compulsive personality disorder up until the DSM-4, but received the independent status as a standing diagnosis in the DSM-5. So when we think about this, we with hoarding disorder, I should say, what we see is that there is typically going to be collecting items that people are later unable to discard, and that these individuals have persistent difficulty in parting with personal possessions, regardless of the actual value of these possessions. And they can include things like magazines, newspapers, old clothes, junk mail, notes, old receipts, pizza boxes, food, um, and that when you try to remove these commonly hoarded items, there's a motivation of fear from the person in discarding something that may be useful now or in the future. And hoarding can cause significant distress or impairment and compromises living areas, which are typically cluttered and congested unless someone else intervenes. When we look at trichomania, which is hair pulling disorder, this is where people pull out their hair and show noticeable hair loss as a result. The episodes of hair pulling, which can be centered on any area of the body, although episodes most often involve the scalp, eyebrows, or eyelashes, occur in bouts that may be brief or may extend for hours. The likelihood of hair pulling is often higher when the individual is under stress, but it can also occur in circumstances when the person is relaxed or distracted, like watching television. Increased tension or urges to resist precedes the act, which itself is associated with pleasure, gratification, or relief. In order to qualify for trichomania, that must cause significant distress or impairment and may not be associated with a medical condition like a skin inflammation or another mental disorder that would better account for the activity. When we are looking at skin picking disorder, people who have skin picking disorder recurrently pick at their skin, causing bleeding, scarring, and infections. The condition tends to first appear in adolescence, often in association with acne. Although it can occur anywhere on the body, it's most commonly involving the head and face. Significant amount of time, sometimes several hours per day, are spent on the activity despite repeated attempts to decrease or stop skin picking. Many individuals who experience skin picking disorder suffer extreme embarrassment and shame as a result of the picking, and the condition is commonly associated with comorbid anxiety and depression. Its incidence may be as high as 5% in some clinical samples. Among the general population, the lifetime prevalence in adult is 1.4%, with females showing a 3-to-1 ratio in prevalence over males. When we look at body dysmorphic disorder, these individuals are preoccupied with what they consider a defect in their appearance, and they engage in these repetitive acts or thoughts related to this preoccupation. Their defect is either imaginary or so slight that the preoccupation is clearly excessive. Their preoccupation causes significant distress or impairment in normal functioning, and it's not better accounted for by another disorder, for example, anorexia or bulimia nervosa. Frequently, the preoccupations in body dysmorphic disorder involve areas of the head and face and include wrinkles, complexion, facial proportions, the size or shape of lips, nose, eyebrows, cheeks, or ears, or thinning hair. However, the disorder can involve any area of the body, showing as excessive concern over the size or shape of hands, feet, buttocks, breasts, chest, genitals, body size, or overall build. There's also a specifier with muscle dysmorphia that was added in the DSM 5 to capture a particular subset of sufferers who believe that their body build is too small or insufficiently muscular. And often people with body dysmorphic disorder can spend several hours a day checking in on the imagined defect or finding ways to cover up or hide it. They may alternate between almost consistently looking into mirrors or avoiding them altogether due to the distress associated with viewing themselves. Their concern can lead them to isolate themselves from others or to avoid things like job interviews, meetings, classes, or dating. Depression, obsessive compulsive disorder, and social phobia may also occur, and suicidal ideation may be present. Not uncommonly, sufferers will typically look to surgery or medical intervention and may even resort to self surgery, although these interventions do not reduce the concern and can actually make the problems worse. So, how do we integrate all of the models from our class? Well, there is a development psychopathology perspective. And this perspective examines how key factors emerge and intersect at points throughout the lifespan. And some of the focus or foci, which is multiple focus, will include things like genetics, the hyperactive fear circuit in the brain, inhibited temperament, parenting styles, maladaptive thinking patterns, avoidance behaviors, life stress and other stressors, and negative social factors. That when you are looking at these 8 areas and you are looking at them from the humanistic existential, the biological, the cognitive behavioral, and even the multicultural perspectives, that looking at these things all together to create this development psychopathology perspective, that by addressing these 8 areas together can help us to help those who suffer from anxiety, obsessive compulsive, and other anxiety related disorders, including social phobias and agoraphobia. I hope that this was helpful. As always, if you have any questions, comments, or concerns, please feel free to reach out to me via email. Don't forget, in the description box below is your extra credit question. All you need to do is answer the question in the comments below, take a screenshot, and upload it by Sunday at 11:59 p.m. for extra credit. Until next time, I hope that you have a great one and be well.